Welcome to the Sales Prospector Show, supported by Leaf, a sales rep and a 5,000 company, helping our clients grow sales by securing guaranteed appointments, qualified leads, and guaranteed contracts for their services and products across the U.S. I'm your host, Gil Pagan. You can find us on all social media channels and at leafasalesrep.com. Thank you for listening in. It's going to be a great one today.
Oh yes, we're gonna have a great conversation today, and I just love doing this kind of stuff, talking about innovation and technology and ways to do things better, particularly in the healthcare space, one of the verticals that we play in. And I enjoy talking to smart people, and I got a guy that we're going to talk about right now, and his name is Dr. Mark Kestner. He is I believe, the Chief Innovation Officer of MediGuru, which is an interesting platform, and they provide a software solution, and we're looking to talk about that, and we're going to talk a little bit about his background. We're going to get into some of the technical stuff, but I wanted to invite here Mark to talk about the things that he's working on. And Mark, welcome to the show.
Thank you. It's good being here.
Yeah, we're looking forward to a great conversation. Listen, tell us a little about your background. I mean, you're a physician by training, right? Clinically. I mean, you got other background stuff, but you're a doctor by training, and you got MD after your name, right?
Right.
Doing some interesting technology stuff. So share with us a little bit about that history and about you, and then we'll get into the mechanics of everything that you're working on right now.
Yeah, so I did my undergraduate degree. I was studying to be an engineer and happened to apply to medical school and got in. And University of Michigan was trying to put kids back in the Upper Peninsula of Michigan, where I lived, as primary care physicians. Well, I guess I had a different idea about that. I ended up becoming a general surgeon, joined the Army for fun, practiced medicine in the Army for about 7-8 years, then was a trauma critical care surgeon because I did a trauma fellowship during my Army training. Did that for a couple of systems, and then went into healthcare administration while I was still a physician. So I was a chief medical officer, chief quality officer, chief innovation officer in multiple health systems across the United States. And when one day, while practicing as a trauma surgeon, I basically got fed up with everything being broken around me, and that healthcare needed to change. So I quit clinical medicine, got my MBA, spent a year studying physician engagement at Gallup University, figuring the only way we were going to get any better is to get physicians on the team. Was a chief medical officer at a number of healthcare systems, again, across the United States. Ultimately went into consulting with a bunch of engineers and finance guys, and developed what we called Air Traffic Control Center for Healthcare to help throughput. Did that for about 5 years, and then went into venture capitalism, or venture capital groups, where we focused on the business of healthcare. What are the solutions for the business of healthcare? Went through a couple acquisitions, and then suddenly ended up with MediGuru. And the reason I ended up with MediGuru is because I had implemented telehealth solutions in a number of healthcare systems across the United States, but they were always in the insurance sphere. How do you lower costs for the insured population, whether you're a self-insured employer, whether you're selling your services to other large healthcare systems or other large employer groups? So when the pandemic hit, none of those solutions, in my mind, were built for clinical care delivery, nor was the model of care delivery appropriate. And so the timing for joining MediGuru, I felt, was perfect, because basically we are building it from the ground zero in delivery systems.
Wow. That's interesting. Just the background story of working in healthcare as a provider, and the Hippocratic Oath, right? Do no harm, right? And taking care of patients, right? And then flipping into other, technology kind of roles and innovation, CIOs and that kind of thing, and then going VC, which, they have that terminology that they don't like as much, but some of them call it true and accurate, the vulture capitalists, right? And they're about, so you're about, not you, I'm saying in general, doctors providing care, taking care of the patient, and then the VCs are trying to get as much dollar and squeeze as much revenue and out of that, so they can get an exit, right? Make a lot of money and an exit. Then you got the insurance people who don't want to give you, the care because they want to hold back as well. So you kind of touched a little bit of everything there, going into something you're doing right now, which brings a very interesting perspective, right? Because you've done a couple of different things, and 7-8 years and here, and then a few years there, and very fascinating story. Very, very interesting story. Thank you for sharing that. And MediGuru, when we started talking initially, we had this conversation around EMRs and technology and the like. So tell us a little bit about MediGuru and actually the simplest way in to understand it for our audience, and I'll may interject on some of the questions there when you're sharing, because our thought will come to me, and and I don't want to lose it, make sure that our audience catches it. Go ahead.
Yeah, so what we do is we provide customized software solutions that are white labeled based on your workflow, or what we would consider to be an optimal workflow. And so we spend a lot of time with clients walking through their processes. The other thing that we recognize is that you can't change everything all at once. The human mind and healthcare won't tolerate it. So we follow the tenets of the diffusion of innovation, which means you empower a small group of people to design a new process, you test it, and then you diffuse it. And so I always like to say we're the external force causing people to change, but unless you have an internal champion, somebody who's well known, that can be the change agent in an organization, we probably are wasting our time with that client. And so we're very particular about, number one, checking the box to make sure that the organization is ready for change and that they have a change agent at the top. The other thing that we're doing is we're looking at all of the neglected areas of healthcare, primary care clinics, people that are now going at risk, skilled nursing facilities, palliative care. We're looking at all the areas that we think we could add value to the care delivery model. And ultimately, it's the direction that we're going in the US to overall improve the quality and decrease the cost of care. So if people are interested in that conversation, I think we can provide a solution for them.
What typically promotes the change, in the organization, right? So if we're looking at healthcare delivery from a entry point of primary care, and you're getting into to seeing a doctor for your annual checkup, right? Or you're going into a specialty, provider, let's say cardiologist, dermatologist, they have a workflow, right? You call, you go online, one or two the options, and you set your appointment. You walk in, you see the front desk person, usually a clerk. They take your insurance, make sure everything's verified, take your ID, and then they send you, put you in the waiting room, then they put you into the exam room, right? So there's a workflow. Medical assistant comes in, talks to you, may take your pressure, touchy-feely, right? And then they say, well, the doctor will be in a minute, right? So doctor comes in, right? So there's a process, right? Workflow. So where do you guys come in? And I know you just shared, you kind of gave a disclaimer. So we want to work with people that are looking to change their process, right? And then have a champion inside. So how do they even know they got to change the process? That make sense?
Yeah. So I think first off, the customer is going to make us change because the customer's expectations have changed.
You mean the patient?
The patient
Okay.
or the customer, right? And so the idea of the old workflow of the waiting room, that's a waste of time, right? You should have been able to fill out all that paperwork before you ever got there. You should have gotten an email. You should have gotten an appointment time. You should check in virtually, right? And you should walk into the office and go directly to an exam room. You should have access to a member of the team to answer any questions without having to go up to the desk clerk. And in fact, our goal is to eliminate steps along the way to streamline the process and to use to use all the tools we would use in a virtual visit, in a real-time visit, and sort of provide a hybrid type of care delivery model. And so I think, the client is, or the patient is going to force change. And then the pandemic has forced all of us to look at how we do things and can we do it better and safer. And I think that's going to go on for a period of time. And the good news is the pandemic has forced change within the system. That's probably the only good news about the pandemic. But I do think it has forced us to make sure that we're leveraging every member of the care team. The American College of Surgeons, or excuse me, the AMA has estimated that we'll be 130,000 physicians short by 2030. So we better make sure everybody's life is much more efficient and we're using tools that will improve our efficiency. Otherwise, we're not going to have enough physicians going into the future.
So you're banking on, again, I said the bank, the MediGuru, right? The model of the change being pushed by the patient, by the customer, the consumer, the client, us, right? Because I'm sure although you could probably diagnose yourself, probably, but I'm sure you have a physician that takes care of you and that kind of thing. So we will move the practices, the service delivery to our needs, right?
Right.
And I guess the follow-up question I have to that is because when I was running primary care centers and ambulatory surgery centers and ERs in another life as an administrator, we were always trying to get as many patient visits in to the doctor's schedule so that we could bill. Okay, that was I'm calling it what it is. Ignore the music. Ignore the music. There you go. So that said, it wants to go on again because we're having a great time here. So it was trying to get as many visits into the doctor, so that we could bill and obviously be profitable and cover our overhead and all those kind of things. So my question to you is, I'm assuming if we're streamlining this process and it's driven by the consumer, right, where they go straight into the doctor's office, the exam room, and they're not waiting in the waiting room. In theory, me, former administrator, would like say, well, they could probably see more patients. Is that a fair assessment?
Right.
Okay.
So
doctors may not like that, but
no. Well, the interesting thing is that 7 out of 10 physicians are now employees. That's a huge shift, right? And so as an employee, they have to be managed. So you have to have and engaged. And the most important factor to engage in the workforce is empowering their manager to give feedback to that employee. And so if a physician needs to improve their throughput and you have the data to show it, then that's invaluable feedback. I, at one point in my career, was the medical director for the hospital services at the Lovelace Clinics, which was an integrated delivery system. They were all employees. The driver of behavior in the Lovelace Clinics was far different than the driver of behavior when I went out into private practice. Out in private practice, it was to make money. When you're an employee, you're trying to provide optimal care. An employee in a capitated environment. And as increasingly employed physicians are going to allow a healthcare system to transition to at-risk contracts, which is basically going to be what the future holds.
Wow, yeah, that's interesting. You're right. I forgot that there was a lot of the doctors are now employee. They used to call them hospitalists. Those are the ones that are at the hospital. But you have other ones that practices have been absorbed by healthcare systems, and they're basically salaried docs.
Right.
Right. Okay. But I would think that maybe correct me if I'm wrong, that there's still I know the hospitals are not for profit. I get it. Most of them are anyway, with the exception of the for-profit chains. Okay. That salary doc, they want to maximize the efficiency of that doc. I mean, that's fair.
So I think, for primary care clinics, increasingly they are banding together and not being associated with a health facility. So you're seeing large primary care networks that basically may or may not use the hospital services. Increasingly, the CMS and a lot of the insurance are making procedures that used to be money-making procedures for inpatient, outpatient procedures. And ambulatory surgery centers are now efficiently delivering care that used to be only inpatient care. So I think, and I think another sort of interesting factoid is that pharmacies are now employing physicians. So you have CVS Pharmacy, who has a large primary care physician group, and they're going to maximize that physician group and support the practice with nurses and pharmacists as compared to the physician, coming up with a solution all on their own. So I don't know that the future of medicine is necessarily going to be hospital-based. It's going to be outpatient-based, and how that is supported will be dependent on that employer.
Wow, that's fantastic. Yeah, and for our audience who don't know this, I know the healthcare people will know, CVS owns Aetna. Aetna is an insurance provider. CVS has walk-in clinics. So you could see where they're going with all of this kind of, ambulatory care, which has been moving primary care into the ambulatory environment for years, and different locations, urgent care and all that. You can see where they're going from a strategic perspective: control the patient, better care, lower cost, all that kind of stuff, get them into they're paying rent anyway for the CVS facilities where they're renting space. So might as well maximize that, right? That environment. So I know you're writing a paper around, hybrid care delivery, right? Which I had the benefit of reading. Thank you for sharing that interesting terminology, right? And that typically, for the audience, telehealth, telemedicine that has been growing before the pandemic, but exploded during the pandemic. Was really more of a kind of a backup option, secondary option to the office visit. We typically go in and see the doc, nurse practitioner, PA, and we get diagnosed, we get a prescription, we go out. That's typically the way healthcare is kind of structured. And then if you can't make it for some reason, a televisit was kind of scheduled. In your thought process is that this new era of providing care is going to be that telemedicine is going to be an option, not necessarily a backup. So talk a little bit about that and how that you see that happening in healthcare.
Yeah, so I think, virtual care for the provider space during the pandemic really became a bolt-on of multiple solutions that were never designed to deliver care virtually as primary care visits. And so what we're trying to do is sort of take the best of virtual care and see if we can't marry that to and make it similar to an in-person care, so that both of them are walking in parallel. So what I mean is, whatever tool you're using for virtual care, you're also using for an in-person visit. We're going to blend the both of them together. So as an example, the waiting room as the example, let's blow up the waiting room on an inpatient visit and use the tools that we use for a waiting room as a virtual care visit. When the physician sees you, let's make sure they're only looking at one screen for whether it's a virtual visit or whether it's an in-person visit. Let's make sure that you're auto-transcribing and translating and auto-dictating the note with the same tools as an inpatient visit as well as a virtual care visit.
You're mirroring everything you're seeing.
Exactly.
Wow, okay.
And so we don't want to duplicate. We want to make sure that we're using one tool for both instances. And I think, as we evolve, it's going to be apparent that you can manage a lot of people virtually, and that the reason to have them come into the office is going to end up being few and far between. There was recently a paper that came out that said people with diabetes or congestive heart failure or chronic diseases do extremely well if they have virtual visits, as compared to what they historically did was go into the office and wait. They can be managed virtually and maybe just need one visit a year, if that.
Think about the shift. I know you shared in your paper that it's going to take a couple of years, almost like the implementation of EMR and EHR took years for it to happen, and financial incentives, by the way, by the government to push providers to adopt that, right? And then penalize people if they didn't do it. So it's like, the carrot and the stick and all that kind of stuff. So it's going to take, from a provider perspective, meaning the physicians who are used to doing this already in a current system, to learn that process, and then the ones that are coming out of medical school and the nurses and all that to kind of be trained in their clinical setting, lack of a better word, or their classroom instruction somehow of it is part of the delivery of care, not in office only, but also virtual. That makes sense?
Yeah, so I think the mindset is shifting because physicians are now part of a team as compared to being in charge, right? The physician used to, issue orders and people followed them. And now I think increasingly what we want to do is maximize every member of the team, have them operating at the top of their capacity, and offload a lot of the burden that has fallen to physicians historically. So when the pandemic started, basically what they gave the physician was, a video call on top of their EMR and said, have at it. What we want to be able to do is say, well, wait a minute, does the physician need to do all of that stuff? Or can we offload it to somebody else? When you look at the satisfiers in healthcare delivery, the biggest dissatisfier for the physician is the administrative burden associated with dealing with care.
It's still the same.
Yeah. And so what we want to try to do is offload that administrative burden on the physicians as much as possible.
Yeah, and that's still the same when I was running clinics in 2002, 2001. It's still the same. And it's interesting. A lot of professions have the same problem. Teachers, same issue. Administrative paperwork, it's just a nightmare. So it's exactly me too. I don't like doing any of that. So but it's just part of it. Looking at all this kind of work, like when you walk into a doctor's office, take us through a little bit about the MediGuru kind of approach and the kind of like some of the mechanics. What I caught when I was reading some of the documentation you provided was that everything that can be done in the office would be done pre-online, like the pre-workup, the history, the notes, insurance verification, meds, all that done online before your official quote unquote check-in into the virtual exam room or office. So take us through a little bit about how MediGuru kind of works through a situation of a bad workflow to kind of smooth that process with the new platforms, and share a little bit about that.
So I think the best example is I went to get my vaccinations at Safeway, the grocery store. I filled out the same paper form all 3 times. When we think of an in-person visit, it's not uncommon for us to hand a clipboard and a piece of paper to the patient. It's the same patient they filled out the last time, filled with the same misinformation because they forgot or whatever. And so I think what we're trying to do is say, how can we off-burden that? How can we give the appointment and all of the paperwork to the patient a week beforehand or a day beforehand and have them fill it out at their leisure? Or better yet, has anything changed since your last visit? Are you still on these medications?
Right. Check, done.
Exactly. And oh, by the way, we can then have the medical assistant validate all of the non-clinical parts of that. We can have the patient raise their hand in a virtual environment if they have a question and chat with somebody on the team. All of that can be done well in advance. We can even do insurance verification, and which we're going to have to do with the No Surprise Billing Act. We have to make sure that this patient is in our network. That can all be done pre-visit versus what we do right now, which is give the patient a clipboard, have them sit in a chair, and oh, by the way, after the visit, find out that they weren't supposed to get care here anyway because they're out of network.
Oh,
so
yeah, and that happens, I'm sure, a lot.
Yes.
Wow, yeah, that's excellent. I guess the ideal people, that decision makers that you would like to be speaking to, whether it's a private practices that are underneath a health system, or as
Mhm.
independent practices, although there's still a lot of them out there, by the way, that have not bought into the network kind of infrastructure. So talk to us a little bit about the ideal people who should be talking to you. They have a pain point. Who is that ideal person?
Yeah, I think, I have my bias that it needs to be a physician leader or a chief medical informatics officer who's struggling with how to make life simpler. It can be a chief nursing officer who recognizes that the team isn't working functionally. Increasingly, I'm not sure it is an administrator because I don't know that they understand the pain of providing the care at the front line. If it is an administrator, I need to make sure there's a strong physician leader that's also going to change the behaviors of their peers. Physicians are natural skeptics. And sometimes, when somebody comes in and says, we're going to make a better flywheel for you, it turns out to be more complex. But we want to make sure that they have one of their peers that is basically telling them it's okay to jump in and, let's start somewhere, right?
So all the examples, I want to make sure I understand, all the examples you raise seem to be, if I'm correct, hospital based kind of, because a CNO hospital is what I think of. That's chief medical officer hospital is what I'm thinking of. Though they could be in a nursing home, though. You can have those two as well. So were you really referring to hospitals when you just said that?
No.
Okay.
Most of our clients are large physician groups at risk.
Okay, gotcha.
Right, and they don't have a hospital affiliate. Well, they're affiliated with hospitals, obviously.
Right.
They send their patients to hospitals, but I think that group specifically is looking for a way to deliver high quality care at a lower cost. And so when they're willing to do that, they know that what they've been doing all along isn't working, and they have to start changing the way in which they're delivering care.
So large physician groups, then multiple unit locations, that kind of thing.
Yes.
Some could be regional players, right?
Right.
That obviously could be hospital affiliated, but that I gotta assume that's fine too. But they see the pain point and want to, and obviously make things more efficient.
Yeah, and I think the other thing, we're having a lot of conversations with, like I said, home health agencies or nursing home agencies, trying to understand what is your workflow? Why doesn't this work? How can we just talked to somebody this morning that said, yeah, we bought virtual care for all of our nursing homes and nobody uses it. Well, let's figure out why that's happening. Well, there's a lot of reasons why it happens, but we know that when outcomes are looked at, people that didn't go back to the hospital for minor things or didn't deteriorate because they were able to be cared virtually, that they have better outcomes. And so I think there's going to be a lot of pressure on those types of facilities also to require virtual care in the future.
Yeah, I think that home health is clearly a major an issue, or the opportunities are there because they are, I just know this, they're extremely inefficient. They have all types of level of people that are doing different things and they're out in the field. I mean, mapping software. We had one of our other conversations with somebody else. That mapping software for outside sales can be applied to home health because of patients and where they are and just being more efficient. It's just a lot of stuff there that sounds like your platform would help. And it's a SaaS model, right? It's a monthly billable. Is it a per seat, per login kind of deal, or is it a license for the whole facility? How does that work?
Yeah, so what we try to do is it can be priced per minute, but it's very quickly, as a customer comes on board, they realize that model isn't sustainable. Maybe, once they start implementing it, price per minute when there's a small group using it, but then it's really priced per team. So we don't, if a physician, a nursing assistant, and a nurse are part of a team, we price it on a monthly basis per the number of teams that you have.
So you can have 7 people in a team and it's just one price for that team, not per head.
Yes,
Okay,
exactly.
gotcha. And well, that's kind of good because you can also pilot stuff
Yes.
with a team, which is great.
Right, exactly. And I think most everybody over the course of time is going to pare down their team to maybe at most 3 people.
Mhm.
But at least during the change process, we want everybody to buy off on it, and we don't want price to be a barrier.
Yeah, and my experience has been that when I go to my provider, it's usually, assuming the medical assistant hasn't changed, it's usually the same medical assistant serving the provider. They have the chemistry, they work well together. She moves with how she moves how she moves. I mean, they kind of work well together, almost like a dentist with a dental assistant, very similar in nature. They kind of understand each other and make it, why change that? You know what I mean?
Right, exactly.
Yeah, so that's good. So and it's per month per team kind of mechanism, correct? Is there, you guys
Correct.
do an onboarding training with the team on site? Is it all virtual, Zoom?
Well,
How's that work?
it's right now it's all virtual.
Right.
Yeah,
Under
right.
normal conditions, yeah.
Under normal conditions, we usually like to be at least initially on site, just so that people get the hang of the tool, right? But we spend a lot of time virtually, even in under normal conditions. I think it works out well. And then, we sort of go in phases. A user isn't going to make all the changes up front. They're not going to blow up the whole system in which they deliver care. And so we usually start out with one piece of the delivery model and start to implement and innovate over time.
So and you're I'm assuming EMR agnostic, I
Yes.
suppose. Okay, so because some of the Epic is a monster, right, in the healthcare on the hospital side, and there's a couple of other ones there. Mark Kestner is doing some stuff, and Cerner, and there's quite a number of different EMR. So you're agnostic to that, and doesn't really matter. You're more at the process, I guess, is what you're looking at. Okay.
Process and integration.
Right, exactly. No, that's fantastic. So as far as the rollout for 2022, are you looking at particular focuses across the country? Are you looking at, like you say, physician practices and trying to work on home health? Is there a area of focus for you in 2022?
Yeah, I think we're looking at large provider groups that are going at risk as of number one.
You say going at risk, what do you mean?
When they say, I'm going to deliver optimal care for you for $30 a month.
Okay, got it.
Per patient per month, and $30 is probably way underscored, but as an example, I think we're also looking at we're carefully looking at what the value proposition is for home health, skilled nursing, palliative care. We're not entirely sure that we found it there. There's an interesting model that's evolving in the market where companies are propping up providing preoperative services. And I'll give you an example. Let's just say you are referred because you have knee pain. Instead of going to the orthopedic surgeon where, oh, by the way, you can get a knee replacement, you're going to go to this service where you'll get therapy. You may get depression screening. You have 6 weeks of physical therapy, and miraculously 50 to 70% of the patients get better without surgery. So that lower cost, improved outcome. Of the people that go to surgery, they're going to need virtual care afterwards, physical therapy, occupational therapy. And so all of that stuff can be done virtually. And so, or a majority of it can be done virtually. And so we're looking at that type of model also. So I think, as we look at the market increasingly, because the market dynamics are changing and because the finance is changing, we're sort of, I don't want to say following the money, but looking at the value proposition and making sure that we're consistent with that value proposition.
No, that's great. And you guys are, again, based on the model, looking at it a lot differently when it comes to integrating what you call the hybrid care delivery model, virtual care, and making it part of the actual care package for the patient, consumer, client. And it's actually, I haven't seen it thought that way. And that's part of the challenge. You got to educate people on that, right?
Well, exactly. And I think what, when I went to medical school, everything was done on paper. And it was easy to understand what was going on with the patient because there weren't a lot of silos of information. With the implementation of the electronic health record, the complexity of delivering of care got more complex. The silos of information became more complex. And so what we're trying to do is step back and say, okay, well, how can we simplify it and make it sustainable? And sort of that's what we're trying to do.
Wow, that's fantastic. Well, we're talking with Mark Kestner, Chief Innovation Officer of MediGuru and their platform and what they're rolling out into the healthcare system and hybrid care delivery model, and looking at processes, streamlining things, and making our experience as patients better, smoother. And listen, I'm a busy guy. I love being able to check in online and do a virtual thing, and I'm done. 20 minutes, write me a script. Bye. I'm the ideal candidate for high-level executive care. There's groups that do that, by the way. All right, yes. Call doctors. They say, "All right, Gil, here, we're good. Yeah, bye." I love what you guys are doing, just because personally, I'd love to be in and out in 15, 20 minutes, and not even have to go to the office. Stay here, right?
So when we look at our models, we look at it from three perspectives. We look at it from the patient's perspective. We look at it from the physician's perspective. We look at it from the team's perspective. And we try to pull data from each one of those to, over time, prove that we've made things better.
Excellent. We get to the point now of our discussion, and we're not all about business and making money and all those kind of things. So we get to the fun part here. Not that this wasn't fun, but get to the part about you and and you a little bit personal. So I'm going to ask you a couple of rapid fire questions. And you
can
answer nothing complicated. Okay. You being a doctor and all, you should be able to handle it. Okay. So that said, like coffee, hot or cold?
Cold.
Cold coffee. Okay. Pizza? Are you a pizza eater?
Once a week.
Once a week. Oh, not bad. Burger?
No.
No burger. Okay. How about hot dogs?
Occasionally.
Occasionally. Okay. Tell me about your driving, or you're riding a bike, or you're working out regimen. Are you listening to a podcast? Are you listening to music? Are you listening to nothing? And just doing your thing.
Number one, I don't drive. I don't even own a car.
Okay.
I live in Washington, D.C., and I walk probably a lot more than I should, 10 miles a day.
Good for you.
I count my steps. And while I'm doing that, I'm listening to podcasts, I'm listening to the news, and I'm listening to music.
All right. So a little bit of everything there. Okay, great. So before the pandemic, were you a Netflix, not that you are now, Netflix, Amazon, Hulu screamer, or versus I want to go into the movie theater, I want to see a movie and have the experience, surround sound, popcorn, and a soda?
No, before the pandemic, I was traveling and I was a Netflix user. But I was traveling every week a lot. And then that suddenly just came to a screeching halt.
Are you a binger on Netflix?
So since the pandemic, my wife and I have stopped watching TV.
Okay. Interesting.
Yeah, so we don't watch TV. In fact, I can't even remember the last time I watched TV. We read books and I listen to podcasts and listen to the news online.
Are you a Android or an Apple person?
Apple.
Apple, okay. Creative element, Apple, it's kind of good. So yeah, that whole ecosystem.
Right.
Yeah. That tells us a lot about a person too, by the way. People don't realize that. That said, so if you had and this doesn't have to be business related, okay? It could be, personal. If you had a superpower, what would that superpower be?
Oh.
And you could take a second on that. Okay, it's some people answer that question really quick, Mark, but they don't think about the complexity of something like that, the superpower. And you're a little bit different, actually a lot different because of what your background is. You know what I'm saying? So
So when I was in consulting, and this may sound a little off, but whatever.
Off is good.
There is a video called Leadership Lessons from the Shirtless Dancing Guy. And I used to go into the conferences and I would show that video and the executives would think I was crazy, right?
I love it.
Like, what is this guy doing? And so and I used to love it because there was this guy at a rock concert who was dancing and everyone was watching him thinking he was weird. And then all of a sudden a person goes up and they start to translate what the shirtless dancing guy is for the rest of the crowd. And before the video is all over, everybody's dancing. So what I think I'd like as a superpower is the ability to make people change.
Wow. Yep, that's admirable. Thank you for sharing that story. And so what was the name of the video? Leadership Lessons from the Topless Shirtless Guy? Is that what you said?
No, Leadership Lessons from the Shirtless Dancing Guy. You have to look at it and it'll make you laugh.
No, I will. I'm gonna look at it and I may use it. I'm kind of like that. So and that's okay. So, and the last thing, if you had the ability to go anywhere in money and time, not an issue, where would you go?
Oh boy. Well, we've traveled pretty much all over the world. I hate to say that.
That's good. Good for you.
Yeah, no, we have. We lived in Germany. We've been to the Middle East or Far East. My wife grew up in the Middle East. We lived all over the United States. I like Washington, D.C.
Okay. And there's nothing wrong with that.
Yeah.
And that's okay.
Yeah.
And Washington, D.C. is lucky to have you.
Yeah, well, thank you.
That's good. That's a good thing. And you get to walk around there too a lot.
Oh, yeah.
From what you said, yeah. Well, listen, we've been talking to Mark Kestner from MediGuru, the CIO. Listen, it's been great chatting with you, and you guys are doing some great, wonderful things there. And obviously, if they want to get in contact with you, what is the best way to do that? If somebody wants to talk to you, reach you somehow, share some details for the audience so they can find you.
Yeah, I post a lot on LinkedIn.
Okay.
So the best way to get a hold of me is messaging me through LinkedIn. I think everybody knows that. Everybody that sort of travels in professional circles has a LinkedIn profile. So I think reach out to me via LinkedIn. That's
Excellent.
great.
Excellent. And that's fantastic. Listen, it's been great chatting with you. All the best to your organization, to MediGuru. I'm sure they are lucky to have you. Your background is deep and interesting. And I do wish you the best year this year that you've ever had there, that you kind of blow the doors off and you bring on the clients and, everybody's happy with what you're doing and you move and bob and weave as you need to grow this business. I wish you guys all the best.
Thank you so much.
Good talking to you, buddy. All the best. Okay, man?
Hey, bye-bye.
You well. Bye-bye.